In this video, we present 3 cases of peroral endoscopic myotomy, or POEM, with extended proximal myotomy. The first patient is a 15-year-old male presenting with recurrent dysphagia after a laparoscopic hilar myotomy and 2 pneumatic dilations. Repeat high-resolution manometry shows a spastic segment extended proximal to the prior myotomy site. Initial endoscopy shows a pseudodiverticulum at the site of the prior myotomy, as evidenced by time barium swallow. POEM, by its endoscopic nature, allows for an extended proximal muscular division accessed through a submucosal tunnel. In this patient, a 2 cm long longitudinal mucosotomy is performed 16 cm proximal to the esophagogastric junction to initiate the submucosal tunnel. Using principles acquired by experience in endoscopic mucosal resection, the mucosotomy is initiated proximal to the myotomy start site to enable a proximal safety mucosal flap of 3 to 4 centimeters. The scope is then maneuvered into the tunnel. A combination of electrocautery and hydrodissection are used to create a 19 cm long submucosal tunnel. In this patient, the tunnel is performed on the posterior wall of the esophagus to avoid the prior hilar myotomy site. After submucosal tunnel creation, a selective myotomy of the inner circular muscle layer of the esophagus is started at 30 centimeters from the incisors and extended on 15 centimeters, ablating both the spastic segment as evidenced by manometry and the EGJ. After myotomy completion, the mucosotomy is closed with a series of hemostatic clips. The second patient is a 68-year-old male with type 3 achalasia previously treated with Botox. High-resolution manometry shows evidence of spastic contractions and gives information on the proximal extent of the spastic segment. Patients with type 3 achalasia, diffuse esophageal spasm, and jackhammer esophagus tend to be less responsive to traditional treatment modalities that target EGJ outflow obstruction relief alone, including pneumatic dilation and the surgical gold standard, hilar myotomy. Additionally, the intra-abdominal approach of laparoscopic hilar myotomy poses limitations for proximal extension of the esophageal myotomy. POEM, the novel surgical procedure for achalasia, may have a specific indication in spastic achalasia subtypes. Laparoscopic hilar myotomy classically extends to 6 cm proximal to the EGJ and 3 cm distal on the stomach wall. In this patient, the endoscopic nature of POEM allowed for a 16 cm long myotomy accessed through a 21 cm long submucosal tunnel. Our third patient is a 46-year-old male with type 2 achalasia. Evidence of panesophageal pressurization can be seen on high-resolution manometry. In this patient, diagnostic endoscopy revealed a circular thickening at 25 centimeters from the incisors, with stasis esophagitis proximal to this mechanical obstruction. Subsequent endoscopic ultrasound confirmed the uniform thickening and identified it as submucosal fibrosis without significant muscle thickening, located 15 centimeters proximal to the EGJ. In this patient, A submucosal bleb was created with a solution of saline and methylene blue at 20 centimeters proximal to the EGJ, or 5 centimeters above the area of thickening. A submucosal tunnel was performed on 24 centimeters. This long tunnel enabled the creation of a 19 centimeter myotomy. The step of submucosal tunnel creation may also have a role in the treatment of achalasia. The appearance of palisading vessels, as well as tunnel narrowing, signified the transition between the esophagus and the stomach. In that area, vessels may be coagued with a coag grasper to progress through the tunnel. After this step, the scope is maneuvered into the true lumen, and the submucosal tunnel is identified by blanching of the mucosa. After myotomy is completed, clips are deployed. After the last clip is placed, final endoscopy confirms the absence of full thickness injuries and the patency of the EGJ. In conclusion, POEM, by its endoscopic nature, combined with diagnostic information provided by high-resolution manometry and endoscopic ultrasound, allows for a tailored surgical management of achalasia. It enables more proximal myotomy in patients with submucosal or muscular findings, proximal spastic segments, or failed prior treatment modalities. Outcomes for these subtype of patients undergoing POEM still need to be reported and compared with other available treatment for achalasia.